Hello, everybody. I am Dr. Susana Salazar, OBGYN, and specialized in fertility. Esteemed colleagues and distinguished guests, it's a great honor to be here with you today at this prestigious international symposium. As a specialist in reproductive medicine, I am excited to share insights and advancements of the topic of luteal phase support, a crucial aspect of reproductive care that can profoundly impact patient outcomes. Thank you for the opportunity to be part of this important dialogue. Let us embark on this journey of knowledge together. But what is the luteal phase? It is a period of time between the transformation of the dominant ovarian follicle into the corpus luteum, shortly after the ovulation, and the establishment of pregnancy or the beginning of the menstrual period. During the luteal phase, levels of progesterone and estrogen rise to prepare the uterine lining for the implantation. Maintaining adequate hormone levels is crucial for successful embryo implantation and early pregnancy development. Timing and duration. The luteal phase typically lasts around 12 to 14 days, with any significant deviation potentially indicating a luteal phase deficiency, which can negatively impact fertility. The secretory activity of the corpus luteum is maintained by the pulsatile secretion of the luteinizing hormone from the pituitary gland. However, each corpus luteum has a scheduled lifespan beyond which LH support is not sufficient for its maintenance. In the absence of pregnancy, luteal phase ends with a loss of the functional and structural integrity of the corpus luteum, known as luteolysis. If pregnancy is established, the corporal life of the corpus luteum is extended by the process called corpus luteum rescue. This process requires sufficient amount of human chorionic gonadotropin, Hg, secreted by the early implanted embryo. What's important of the luteal phase support? First, implantation. Adequate luteal phase support helps create a favorable uterine environment for embryo implantation, increases the chances of successful pregnancy. Second, early pregnancy maintenance. Maintaining proper hormone levels during the luteal phase is crucial for the continued development and survival of the pregnancy. 3, improved fertility outcomes. Providing an appropriate luteal phase support have been shown to enhance the successful rate of assisted reproductive treatment, such as IVF. And 4, the patient experience. Effective luteal phase management can improve the patient experience by reducing the risk of early pregnancy loss and providing more supportive environment for the embryo implantation. Now I'm going to talk about the hormones involved in the luteal phase. We already talked about the progesterone that is produced by the corpus luteum. Progesterone is essential for preparing the uterine lining for the implantation and maintaining of the pregnancy. Second, the estrogen. Estrogen levels also rise during the luteal phase, working in conjunction with progesterone to support implantation and early fetal development. HCG, the human chorionic gonadotropin, is produced by the placenta and helps maintain the corpus luteum, ensuring continued progesterone production. And 4, LH, luteinizing hormone, triggers ovulation and also plays a role in the formation and function of the corpus luteum during the luteal phase. Now let's talk about the diagnostic and evaluation of the luteal phase. One of those is the basal body temperature. Tracking the basal body temperature can provide an insight into the ovulation and the length of the luteal phase. Second, the hormone testing. Blood tests to measure progesterone, estrogen, and other hormones can help assess luteal phase function. For example, measuring progesterone day 21 to 22nd of the menstrual cycle, it's very important to know if the patient has ovulated before. Endometrial biopsy. In some cases, an endometrial biopsy can be performed to evaluate the uterine lining and confirm the presence of the luteal phase defect. And also, imaging studies Techniques like transvaginal ultrasound can be provided to access the corpus luteum and also monitor changes during the luteal phase. Which are the common luteal phase deficiencies? First, insufficient progesterone. An inadequate progesterone production by the corpus luteum can lead to a suboptimal uterine lining and increased risk of implantation failure and early pregnancy loss. Other is shortened luteal phase. A luteal phase that is shorter than the typical 12 to 14 days can also compromise the uterine environment and reduce the chances of successful implantation. Another one are the ovulation disorders. Underlying conditions can affect ovulation, such as PCOS, polycystic ovarian syndrome, can disrupt the normal luteal phase and contribute to fertility issues. And inadequate corpus luteum, factors like advanced maternal age or previous ovarian surgery can impair the formation of the corpus luteum, leading to luteal phase deficiencies. Let's talk about the symptoms of luteal phase deficiencies. Irregular menstrual cycles. Patients with luteal phase deficiency may experience shorter or more irregular menstrual cycles, as the corpus luteum plays a crucial role in regulating the menstrual cycle. Another one is spotting or bleeding. Inadequate progesterone production can lead to spotting or light bleeding during the luteal phase, which can be an indication of luteal phase defect. Another, infertility or recurrent pregnancy loss. Luteal phase deficiency is a common cause of infertility and can also contribute to an increased risk of early pregnancy loss, as the uterine environment may not be optimal for embryo implantation and development. Now let's talk about luteal phase support strategies. Luteal phase deficiency is a common result of assisted reproductive technologies, ART, characterized by inadequate or inappropriate progesterone production. This inevitably compromises the successful establishment and maintenance of pregnancy and has led to the critical requirement for luteal support protocols. Luteal phase support in IVF. The provision of exogenous progesterone to supplement endogenous progesterone production has become a routine component on ART. The wide variation in clinical approach means that the choice of luteal phase support for couples undergoing ART is far from clear. Evidence suggests that current global preference for luteal phase support via vaginal progesterone in tablet forms administered for the day of the ovul's ejaculation and maintained for 8 to 10 weeks. The medication we usually use for the luteal phase support are free progesterone, HCG, GnRH agonists, and also estrogen. Synthetic progesterone or natural micronized progesterone are commonly used to supplement the luteal phase support and implantation in every pregnancy. HCG, human chorionic gonadotropin, can be administered to stimulate the corpus luteum and maintain progesterone production during the luteal phase. GnRH agonists, gonadotropin-releasing hormone agonists, may be used to support the corpus luteum and prevent premature luteal phase deficiency. When we talk about luteal phase support in IVF patients, we must ask ourselves the following questions. First, route of administration. Second, time to common supplementation. Another one is duration of the progesterone supplementation. Because although it is clear that exogenous luteal phase support improves the rate, there has been significant debate and research regarding timing, dose, and routes of progesterone administration. With regard to the timing of progesterone initiation, there is endogenous progesterone production from the corpus luteum after HCG triggering that persists until 5 to 6 days after oocyte retrieval. Therefore, it's likely that progesterone supplementation should be initiated before day 5 to 6, but it is not clear how early should progesterone be initiated before the decrease of the endogenous progesterone. It has also been proposed that early progesterone administration may be of benefit before the embryo transfer, by the smooth muscle relaxing effect of the progesterone in the uterus. The question is, does progesterone supplementation improve clinical pregnancy rates in women undergoing fresh IVF cycles? This meta-analysis, published by Fertility and Sterility in 2019, showed there was a significant benefit to clinical pregnancy rates of either the route of progesterone supplementation compared with no supplementation. Numerically, it was equivalent to increasing mean pregnancy rate from 14 to untreated women to 30.7 after oral, 36.4 after vaginal, 36.6 after subcutaneous, and 44 after intramuscular progesterone supplementation. Let's talk about oral progesterone. The routes of progesterone administration exhibit different pharmacological profiles. Oral progesterone has very poor bioavailability, does not produce a sustained plasma progesterone concentration, and fails to elicit an adequate endometrial secretory response, and also produces sedative metabolites. In addition, a negative impact on implantation was observed after oral micronized progesterone versus intramuscular or vaginal. Administration of the orally effective dihydrogesterone led to clinical pregnancy similar to those after vaginal micronized progesterone support. Recent evidence also suggests that oral dihydrogesterone is well tolerated and is not associated with significant fetal or maternal sleep risk. Despite this, oral progesterone has very low current clinical issue. So, oral micronized progesterone for luteal phase support in ART not only results in significantly lower rates for pregnancy and implantation compared with those for intramuscular HCG progesterone, but also causes more side effects. Administration of the orally effective dihydrogesterone led to clinical pregnancy rates similar to those after intravaginal micronized progesterone support. Now, vaginal progesterone versus intramuscular progesterone, which is best. Vaginal progesterone, there are limited numbers of vaginally administered progesterone preparation, including progesterone capsules of 1, 2, and 400 milligrams natural progesterone, and progesterone gel, 90 milligrams natural progesterone. Intramuscular progesterone. Two recent meta-analyses, including a prospective randomized trial, also indicate that intramuscular progesterone confers the most benefit compared with oral or vaginal administration. Intramuscular administration of progesterone results in higher, more sustained serum levels than vaginal administration. However, vaginal regimen undergo rapid absorption to achieve higher endometrial tissue concentrations. The other question is, when do we should start the supplementation? It's more beneficial when it commences between the oocyte retrieval and the embryo transfer. Commencing progesterone supplementation on the day after the oocyte retrieval has most beneficial trends in clinical pregnancy rates. Delaying supplementation until the third day reduces clinical pregnancy rates versus starting the day of the oocyte retrieval. The other question is duration of progesterone supplementation. Several meta-analyses were performed to investigate the impact of extended luteal phase support duration. Now, let's talk about the duration of the progesterone supplementation. Several meta-analyses were performed to investigate the impact of extended luteal phase support duration. In 2012, Luteal published a meta-analysis of 6 randomized controlled trials. No difference were detected between the patients who underwent early and late progesterone cessation in terms of live birth rate and ongoing pregnancy rates. A Cochrane review found similar results. Recent guidance, ESHRE, recommended that progesterone for luteal phase support should be administered at least until the day of the pregnancy test. A close look at 4 such surveys conducted over the last decade reveals that the majority, more than 60% of clinicians worldwide, administer luteal phase support until 8 gestational weeks and beyond. This rate did not change significantly over the years. only 24% of clinics in the UK withdraw luteal support at biochemical confirmation of pregnancy. Notably, 40% of clinics reported that they continue luteal phase supports until 12 weeks of gestation. Clinicians must be confident that they comply with the principle of premium non-share or first do not harm before introducing a routine of early luteal phase support withdrawal. Now talk about the doses. This table taken from the ESRE guidance where they explain the different doses according to the rules of administration. The dosing of natural progesterone has involved empirically usually those include 50 milligrams once daily for intramuscular progesterone, 25 milligrams once daily for subcutaneous progesterone, 90 milligrams once daily for vaginal progesterone gel, 200 milligrams 3 times a day for micronized vaginal progesterone, this is what we use, 100 milligrams 2 or 3 times a day for micronized vaginal progesterone in starch suppositories, and 400 milligrams 2 times a day for vaginal progesterone. So which are the luteal phase support strategies? Medication, we already talked about the progesterone. Hormonal therapy, other medications used as estrogen and HCG to support the function of the corpus luteum and promote progesterone production. Lifestyle medication, adjustments to the diet, stress management, and other lifestyle factors to optimize hormonal balance and nutrient receptivity, and assisted reproductive technologies. The incorporation of luteal phase support strategies into the reproductive treatments, such as IVF, to enhance the chances of successful implantation and pregnancy. Another question to the luteal phase support. Estradiol role. The role of estrogen production by the corpus luteum is rather complex. Animal studies have demonstrated that the direct injection of estradiol into the ovaries induces luteolysis, probably due to prostaglandin overproduction. Estradiol priming is essential for the synthesis of progesterone receptors and progesterone-induced changes in the endometrium after ovulation. Estradiol controversy. The role of estradiol during the luteal phase of ART cycle remains controversial. Although some studies reported improved rates of pregnancy and implantation, other studies have not found any beneficial effect on adding estradiol barrier to progesterone for luteal phase or in DNRH antagonists. The cover meta-analysis mentioned before reported no difference in live birth rate and ongoing pregnancy rate, no ovarian simulation syndrome between progesterone with estradiol supplementation and progesterone alone. In RCT, more recent than that meta-analysis, including 220 women, compared progesterone and progesterone with estradiol for luteal phase support, and reported no significant difference in ongoing pregnancy rate, 32 versus 36%. In contrast, our RCT, not included in that meta-analysis, investigated the effect of adding estradiol to high doses of progesterone in 240 women, and reported significantly higher clinical pregnancy rates with estradiol supplementation in women undergoing of long DNRH antagonists and short flexible DNRH antagonist protocol. The recommendation of ESRE is the addition of estradiol to progesterone for luteal phase support is probably not recommended. The justification is the data suggests that estradiol is not recommended for luteal phase support since it does not improve efficacy in terms of labor rates, pregnancy rates, or safely in terms of ovarian hyperstimulation syndrome. Is it beneficial to add HCG during the luteal phase? HCG is equal to progesterone protocols regarding efficacy. However, HCG increases the ovarian hyperstimulation syndrome risk, specifically in high responders and with the dosage historically used, 1,500 units. Studies compared HCG and progesterone for luteal phase support have not been stratified according to ovarian response. Extra recommendation is in HCG-triggered ovarian stimulation syndromes, HCG and luteal phase support in standard dosage of 1,500 units is probably not recommended. So these are the conclusions and the key takes away. Importance of the luteal phase. The luteal phase is a crucial period for successful implantation and early pregnancy maintenance in assisted reproductive therapies. Luteal phase deficiencies, common luteal phase deficiencies such as inadequate progesterone production or shortened luteal phase can negatively impact fertility and pregnancy outcomes. Diagnostic and evaluation. A comprehensive diagnostic evaluation, including hormone testing and imaging studies, is necessary to identify the obvious luteal phase defects. Luteal phase support strategies. Effective luteal phase support strategies, including medication, hormonal therapy, and lifestyle modification, can significantly improve the chances of successful in assisted reproductive treatments. Progesterone is recommended for luteal phase support after IVF-ICSI. The administration routes, any administration route, non-oral, for natural progesterone can be used for pregnancy outcomes. Starting progesterone for luteal phase support should be in the window between the evening of the day of the ovulatory retrieval and 3 days post-ovulatory retrieval. And how long progesterone for luteal phase support should be administered at least until the day of the pregnancy test. We prefer to administer it for more than 8 weeks. Thank you again for joining us at this symposium. I hope you enjoyed this presentation.